In this capture, we're going to take a look at peripheral vascular disease, and that involves both arterial problems and venous problems. So let's start by just doing a little bit of review of the vascular system anatomy and physiology. On the arterial side, we have arteries and arterioles. We also then have capillaries that then move into veins and venules. And that's really important when you think about arteries and arterioles. Those are carrying the oxygenated blood. The capillaries, those are down at the actual cellular level. And this is where the actual exchange of oxygen and nutrients from the circulation into the cells is occurring. And then the venules and the veins, that brings it back up to the heart so the blood can be reoxygenated. There are also lymphatic vessels. We're not really going to go much into the lymphatic piece, but do understand that if your patient has lymphedema or they've had lymph nodes or some of these vessels removed, they can develop edema and swelling around that particular area because that's helping to drain fluid back as well. From the physiology standpoint, looking at the vascular system function, we talked about how it flows, but we think about the arterial side as a high pressure side, the venule as a low pressure side. But hemodynamics and pressures are going to play a huge role in how these disorders manifest and how we manage them. So looking at peripheral blood flow, we're always looking at movement of fluid across the capillary wall. Okay, so we have oxygen diffusing across the capillary wall into the cell. We have waste products moving back over, and you have hydrostatic and osmotic forces. So you have the diffusion of these substances, but what keeps all the plasma from leaking out? And that's really the hydrostatic forces and the counterpole of things like proteins and albumins. Okay, so that's pretty important. You also want to think about hemodynamic resistance, so blood viscosity or how thick the blood is. If your patient is not very well hydrated, I have less plasma and more cells and solutes in there. The blood tends to kind of be more sticky. It's going to be harder to push through. The vessel diameter also plays a role. Just kind of think about this like your backyard hose. Okay, I got the hose running and the water is just going through very easily. But now let's say I start pinching on that hose. I'm changing the vessel diameter. I'm changing the hose diameter. And that pressure has to increase to get past that obstruction. Okay, so all of that's going to play a role. The peripheral vascular resistance regulation, the vasodilation, vasoconstriction, that's also going to play a role in circulation and pressure. The last thing I want to mention with this is collateral circulation, because we're going to talk about some disorders where there's problems with blood flow. And what's so cool about the human body is that it sometimes finds a way. And the body will essentially grow and develop capillaries and blood flow channels that didn't initially exist in order to try to get around a blockage or get around a problem. So it's kind of cool that that happens. But the downside to that is your patient might literally be staying alive because of collateral circulation. And how that develops, especially if it's developing over time, remember that your body can adapt to over longer periods of time, a slower adaptation and do better than if it has a rapid change. So if it's been adapting over a long period of time, that may also delay diagnosis of certain disorders. So looking at vascular pathophysiology, sometimes it's a blood vessel problem. Sometimes it's a pump failure problem. So if I have a problem with the pump, I have a heart issue, I have, right-sided heart failure, left-sided heart failure, that certainly is going to affect, vascular disorders. It could be a problem with the actual vessels themselves. Maybe there's damage to the artery. There's plaques on them. Maybe it developed an emboli, an embolus, okay, a thrombus. Maybe I'm experiencing vasospasm, where those vessels are having spasms instead of a nice, clean vasodilation, vasoconstriction. On the venous side, again, you can have thromboembolus, development of clots, blockages, but we can also have incompetent valves. Remember, in the vein side, we do have valves because the pressure is lower and it's trying to return blood flow from our lower extremities back up to the heart. So, to keep it from flowing backwards, we need to have those valves. So, sometimes a venous problem is an incompetent valve. And sometimes it's just an extremity circulatory insufficiency. So, we're going to look at some different disorders and kind of how this all ties together. The other piece you want to kind of keep in mind is the physiology of coagulation. And I have a bunch of dominoes on there because that's how I want you to think about the clotting cascade. When you talk about hemostasis, so that's basically, keeping you from bleeding, but not forming clots all the time, just spontaneously. It occurs through platelet aggregation and then coagulation. So if I cut myself, maybe I was shaving, I cut myself, I'm bleeding, my platelets are going to go and start plugging up that, particular cut. But I'm also going to have coagulation factors that are going to allow a blood clot to form there, not an entire clot that blocks it, but a clot that blocks off where that cut was until it can heal, and then that clot will then be reabsorbed. So this coagulation piece, there's 4 different coagulation factors. There's actually more, but there's 4 particular factors that require vitamin K for synthesis. Okay, so that's just something to kind of keep in mind as then we get into talking about different anticoagulant medications. So vascular assessment. We already kind of covered cardiac assessment in a previous capture, so I'm not going to repeat that. I really want to focus on the vascular piece. So a focused pain assessment is going to be really important. And in here, I want to mention intermittent claudication. So this is basically pain in the extremities that is occurring, with rest. Okay. Usually it's after excessive activity, and they rest, they're having pain, indicative a lot of times of arterial problems. You certainly want to look at their skin for the color, the temperature. You also just want to look overall at the tone, is there edema? You want to look at the nails, and again, you want to look at your pulses, your peripheral pulses. And there's some pictures there that you want to look at. Now, there is a picture at the bottom part of your screen that talks about the perineal artery. That is not something we typically assess. It's mentioned there because it is used for one of the diagnostic tests. But again, nursing is typically not doing that. So with diagnostic testing, there's a couple things we look at. So the continuous wave Doppler ultrasound, this is all about looking at blood flow and looking at pressures in the arm versus pressures in the ankle. Okay. So we're just looking at that. This will help characterize the nature of your PVD. And basically it's looking at pressures to see, do you have adequate pressure to perfuse? Okay. There's also something called a color flow duplex ultrasound. So this is looking at the actual velocity and blood flow, both in the arteries and the veins. It can also identify if there is stenosis, so narrowing of the arteries, typically from plaque. When we talk about, fat buildup or plaque buildup, and we always talk about it in relation to coronary artery disease, but the reality is that doesn't just happen in the coronary arteries. It happens in all of the blood vessels throughout the body. So the color flow duplex ultrasound is helpful in identifying the location of the disease and evaluating how extensive the disease is. It's also non-invasive and there's no patient prep. So it's a pretty easy test to do. Other vascular diagnostics, certainly the CT, angiography, which we talked about previously, MRA or MRI, where they're actually imaging the blood vessels. And venography is used, again, contrast is administered, and it's basically used to identify thrombosis. So let's get into the actual nitty gritty of the diseases. And I want you to understand that peripheral vascular disease is a big umbrella term. Underneath there, you have arterial disease and you have venous disease. So we're going to kind of hit both. But peripheral arterial disease, or PAD, please do not call it PAD, people will laugh at you. Peripheral arterial disease. So typically, this is a combination of two problems. You have a narrowed vessel because of the plaque, and you also have what we call arteriosclerosis. So this is the loss of artery elasticity. So it doesn't vasoconstrict, vasodilate as easy as it did before. You might call it hardening of the arteries or stiff arteries. Bottom line, both of these are going to cause inadequate blood flow. And as I mentioned earlier, when we talk about vascular things, for this particular portion of the course, I'm focusing on the extremities. But the reality is, this peripheral arterial disease process is the same thing that is occurring in the brain that predisposes a patient to a stroke. It is the same thing that occurs in the heart that will put the patient at risk for an MI. So it's the same concepts. Even though we're not necessarily covering coronary artery disease, I want you to have a basic understanding of those concepts. When we cover stroke, ischemic stroke, as part of Unit 6, a lot of your concepts that you're learning here are going to apply there as well. So you can see in the pictures that are there, how the vessels look over time and how plaques build up. And, by the time you get 40s to 50s, you're starting to see some plaque buildup, more in patients with higher risk factors. And that makes it more difficult that if a clot does form or platelets kind of get stuck on that plaque that's there, a thrombus can develop and you can have an occlusion. Okay, so here, arterial disease, you have inadequate blood flow because of the narrowed lumen and the stiff arteries. You're also at risk for a complete obstruction if a thrombus would actually develop in there and completely cut off circulation. So, risk factors for this. There's certain things that we can't fix. As we get older, we're at higher risk for this. It is what it is. Females, we also get the short end of the stick. That's how it is. Okay? But there are things that are modifiable. Nicotine use is a big one, and that's smoking, chewing, anything like that, because the nicotine in there causes vasoconstriction and vasospasm. Those things are going to reduce blood flow to the extremities. Diet is a modifiable risk factor because we know high cholesterol, high fat diets are going to increase the amount of plaque that is deposited on the inside of those vessels. Hypertension, okay, so controlling that blood pressure, very important. Diabetes, okay, again, remember I said this was a major risk factor for cardiovascular disease. So controlling that blood glucose, keeping that A1C less than 7, okay? Again, other risk factors, dealing with stress, increasing activity, those are things we can look at. So signs and symptoms. So we have intermittent claudication. So again, burning, cramping, and leg pain with exercise, and then it's relieved by rest. Okay, usually takes a couple minutes for it to be relieved, but that's why it's often called rest pain. The other thing they might note is numbness and burning of those extremities. You might see skin, hair, and nail changes. Okay, the nail changes, you kind of think about clubbing for long term, but hair, okay? If you've ever seen older people and you look at the front of their legs and it's all shiny and hairless, they have impaired circulation in those extremities because you need adequate blood flow in the legs to provide the nutrients for the growth of hair. Okay, so you look for that. Dependent rubor, meaning when the legs are in a dependent position, you have red discoloration or purple discoloration. Okay, but then when you raise them back up, you elevate them, that blood is able to get back there and back to the heart. Diminished pulses, so looking at pulse strength, again, very important. So diagnostics with this, again, we're looking at our arteriography, angiography, venography, looking to see the actual structure and blood flow of that particular vessel. We can do exercise tolerance testing to see, how is exercise impacting the circulation of that particular extremity. As I mentioned before, the Doppler ultrasound flow or the duplex ultrasound. Of course, we can look at CT and MRI. Overall, with somebody with peripheral arterial disease, we want to increase the arterial blood supply to the extremity. We want to relieve, manage their pain. We want to attain or maintain tissue integrity. Anytime you have a problem with circulation, particularly to an extremity, they are going to be at risk for the development of ulcers. Now, these are not pressure ulcers, these are arterial ulcers related to a lack of blood flow. And we're going to look at these a little bit more in depth in a little while. But that's a big problem, particularly if they also have things like diabetes, and we already have problems with wound healing. The other goal is adherence to the self-care regimen, because again, this is a chronic issue. It's not, I have bronchitis, acute bronchitis, I go to the doctor, I get treated, I'm going to be good. This is a chronic issue. So, things that we recommend. We do want these patients to continue to exercise. Now, remember, they're experiencing intermittent claudication, so, we don't want them to go out and run a marathon, but we do want them to have exercise, graded isometric exercise. And then usually we'll say, walk till you start hurting, take a rest. Okay, you don't want to overdo it, but you do want to promote exercise because that does help with blood flow. We do want to protect the extremities. Again, because of that lack of circulation, if they were to bang against something or get caught on something, have a cut, anything like that, it's going to make it much more difficult for healing. They really need to avoid crossing their legs, and they should only elevate their legs to heart level. They should not elevate them above that, because that will make it harder for the blood to perfuse down to the toes. Considering the effects of temperature, heat and cold, cold is going to cause vasoconstriction. These people already have issues with circulation to their extremities, so it's really important that they're not out in the cold for very long, that they're wearing socks, that they're wearing, pants to try to keep those extremities warmer to promote vasodilation. We already talked about smoking, stress reduction, diet, weight reduction, low sodium. Medications that are commonly used are antiplatelet aggregates such as aspirin or Plavix. These help keep the platelets slippery so they don't aggregate together and form a clot. So that's going to be really important, especially if they have plaque buildup. Statin drugs are used to reduce cholesterol and lipid levels. So there we're trying to reduce the amount of plaque. Surgical treatments include PTCA, so this is a percutaneous transluminal angioplasty, so they'll actually go in there through angiography, kind of use a balloon to try to help open up those blood vessels, improve blood flow. They can actually do angioplasty and revascularization, so actually doing, you may have heard of a fem-pop bypass, femoral popliteal bypass, where there's a blockage at that part of the leg, and they'll do a bypass similar to how they do a coronary artery bypass, except now we're looking in the leg. A subcategory of peripheral arterial disease is Raynaud's. This is a very, very interesting phenomenon. You'll sometimes see it called Raynaud disease, Raynaud phenomenon. But it is intermittent, sudden, bilateral vaso-occlusion. It usually happens in the fingertips or the toes, and you can see some good pictures of it up there. Signs and symptoms: pallor, it gets very, very pale, it can become cyanotic. Initially it might look red, but there's numbness, tingling, and burning sensation and pain. Patients with Raynaud's, they really need to avoid or minimize triggers of vasoconstriction, so being out in the cold is not a good thing. Central PA is not a good place to live for our Raynaud's people. Tobacco, again, with the vasoconstriction, stress can also cause that as well. You want to be very careful about avoiding injuries to the hands and fingers. This is where we tend to see it the most. Um, Treatment wise, typically we're going to focus on avoiding and minimizing triggers. Um, Calcium channel blockers have been somewhat effective with that. If it's really, really bad, they can actually do some surgery. They can divide branches and cut some nerves there to try to avoid this phenomenon. So we're going to switch to the venous side, to the venous disorders. And just as a general overall term, venous insufficiency, um, basically there's just a problem with the return of blood flow back up to the heart. This can be because of incompetent valves, so the valves aren't working and it's allowing backflow. It could be because of pooling blood, particularly if somebody's sitting in a dependent position for a while and the legs are dependent. It can be because veins are dilated and that causes swelling. There's venous stasis ulcers, cellulitis. The big thing to keep in mind with venous disorders that the biggest risk factor is going to be prolonged sitting and standing, particularly if it's in one position and they're not moving around. Obesity is going to, be a risk factor just simply because there's more weight. There's generally more fluid that has to be moved. Pregnancy is also a concern, as well as thrombophlebitis. And we're going to talk a little bit more about thrombophlebitis and the development of clots. But phlebitis is the inflammation and the thrombo is the clot piece. So looking at these different disorders, for lab and diagnostic tests, if we're looking at the potential development of a clot, one of the tests we'll do is a D-dimer. And if that's elevated, it means that your patient has more predisposed to forming a clot. It doesn't necessarily mean for sure that they have a clot, and it does not identify where any particular clot would be. It just simply shows that their body is more predisposed to clot formation. A venous duplex ultrasound would be helpful in identifying if your patient has a DVT and what particular vessel it's in and how large the clot would be. A venogram, same type of thing. We're using dye to show us what the circulation is, where the blockage is, where the pooling of the blood would be. There is a test called the Trendelenburg test, and that is something that they can do to evaluate vein filling. That's typically an outpatient test, not something that you would really see in the hospital. So signs and symptoms of venous disorders, they also will have leg pain, limb pain. It's typically going to be a very achy, like a heaviness feeling in the extremity, and a lot of times it's after they've been standing for a while. From a clot perspective, we want to really watch calf and groin pain. If there's sudden onset of swelling or warmth or tenderness, that could be indication of a DVT. If the tissue becomes indurated or firm, that could indicate a cellulitis growing as well. From the venous perspective, you can see some brown discoloration. It might be a very dark purple discoloration, but usually it's more of a brown. They typically do have edema, and you can often see superficial veins. I had a professor explain it to me once or describe it once. We had a patient who had really bad peripheral venous disorder, and literally her lower legs and the back of her calves, because you could see the veins and they were like the bluish purple and they were really distended because of all the fluid retention. I mean, literally her legs looked like a road map of Detroit when you were looking at all the different veins and where they went. It kind of reminded me of a road map of the different routes. So looking specifically at venous thromboembolism, or VTE, we like to call it DVT, deep vein thrombosis, which then obviously is a concern for pulmonary embolism, which we discussed earlier in this unit. But there's things that are going on. There's three main factors in here, and we call them Virchow's triad. But basically, there's damage to the endothelial tissue of the vessel. And this could be something from trauma, it could be surgery, it could be local vein damage, from putting in an IV, or repetitive motion injury. So there's some sort of endothelial damage because that's going to stimulate the platelets to come and deposit at that area. The other big factor is venous stasis. And if I have to pick the biggest one, it's this. Venous stasis is the number one factor when it comes to the development of VTE. So this is all the things you know. Patients that are immobile are at much higher risk. We know that obesity and age are also big risks here. Okay, but the biggest one of venous stasis is going to be mobility. And then the last piece we look at is altered coagulation. So, are there medications that are altering coagulation that make them more predisposed to clots? Do they have something like polycythemia where they have, higher numbers of red blood cells? Thrombocytosis where you have increased platelet count, just things like that. There are some actual genetic disorders where they have certain protein deficiencies or they have factor deficiencies that would put them at higher risk too. Where this becomes an issue, and you can see it in the picture that's on the screen, when you have a thrombus that is stationary, it's there, okay? It's on that vessel. Here's the thing. Even if we did absolutely nothing, that person's body is going to break up that clot. It generally takes 7 to 10 days. Your body makes and breaks up clots all the time, okay? But our concern is if that clot is there, we don't want it getting any bigger and we don't want it moving, okay? We often say that, when the clumps of platelets attach to the wall, it creates a fibrin tail. And a DVT is bad enough, but if that clot dislodges, it's then moving in the vascular system along with the blood flow. And that's where it gets up to the heart, to the right atrium, to the right ventricle, and out into the pulmonary artery and pulmonary vessels. And that's where you get the pulmonary embolism from, okay? So a DVT is really important because we don't want it to progress into a PE, which can be life-threatening. So signs and symptoms of a DVT, again, limb pain, heavy feeling, the swelling, the warmth, the tenderness. Okay, that's DVT. The chest pain and shortness of air indicate that that clot has likely broken off and moved, and now we're looking at a PE. So again, our biggest thing here is prevention. Think about your patients that are at risk and what can we do to help prevent this. So we can use things like SCDs, we can use things like TEDs. Depending on the situation, we might use chemical VTE prophylaxis. So this might be sub-Q heparin, enoxaparin. It might be oral warfarin if somebody requires extended therapy. Positioning is really important, making sure they're elevating those lower extremities, making sure they're doing active and passive limb exercises, getting those post-op patients up. Get them up and walking. They shouldn't be sitting or standing for prolonged periods. Even somebody that's not post-op, you should be walking 10 minutes at least every hour to 2. One of the populations that we don't necessarily think a whole lot about, but people that are traveling, whether they're traveling in an automobile or they're on a plane, particularly if they have long travel plans, okay, long distances to go, you need to stop and get up and walk around. Even if you're on a plane ride, even though it annoys the people around you, you need to get up and be walking every hour to 2. Get that circulation going. When you're sitting in the chair, do those ankle pumps and ankle circles. Do your marching with your legs. Get that blood flowing because we see that a lot. Long travel predisposes somebody to the development of a clot. Certainly avoiding smoking. We mentioned the TEDs. Graduated compression stockings, these are different than TEDs, okay? And I have that picture over there too. That true graduated compression stockings, these are applying external pressure to help with venous return to the heart. So these are different than just your standard TEDs because TEDs only apply about 12 to 20 millimeters of pressure, whereas your graduated compression stockings are going to be much more. So again, when we're doing medication management, our goal is to prevent thrombus growth. We don't want it to get any bigger. We don't want it to fragment off or move. And we don't want those clots to recur. So when we talk about pharmacological treatment, we have anticoagulants. Those are going to affect the clotting cascade. So kind of think about the clotting cascade dominoes. I hit the domino and one knocks over and knocks the next and the next and the next and the next. So what anticoagulants do is space out the dominoes or maybe remove a domino here and there. They're still going to tip over. The blood is still going to be able to clot. It just takes longer to do it. Okay? With antiplatelets, they make the platelets slippery. So think about the slippery slope. Okay? Think about that. I don't want those platelets sticking together as easily. Okay? In serious cases where it is a major clot, particularly a PE, if it's lodged in the main pulmonary artery, one of those, they may consider thrombolytic therapy. So clotbuster, Pac-Man. Okay? Surgical treatment, they can actually go in and do a thrombectomy where that could be open or it can be done endoscopically. They might be able to do angioplasty. An IVC filter would be used for a patient that has had recurrent DVTs. And that filter basically sits, the IVC stands for inferior vena cava. So it's basically this little metal meshy type thing that's deployed in there. And blood can still flow through there, but over the small microscopic pores, but that filter will stop any blood clots from actually getting back up to the heart. If you have venous blood clots and they're moving, that's going to catch those clots. Varicose veins, these are enlarged, twisted, superficial veins. We typically see them in the lower legs, and it's all about incompetent valves. So as we get older, we're at higher risk for them. Nurses, we walk and we stand a lot, so we're going to be at higher risk for varicose veins. That's actually why it's recommended that nurses use compression stockings and compression hose when they're working to really help promote that venous return. So treatment-wise, you always want to avoid crossing your legs because when you do that, you're changing the pressure, you're also impeding blood flow to that lower extremity. You don't want to wear socks that are too tight. You want to elevate your legs about 3 to 6 inches above the heart, and you want to be walking at least 30 minutes each day. From a surgical perspective, they can do ligation and stripping of the veins. They can do laser treatments. They can do sclerotherapy. Really, prevention is kind of more the key here, making sure you're using those compression stockings. So chronic venous insufficiency. So when you have this chronic issue where the blood is not being returned back to the heart in an effective way, you basically have the pooling of the blood down in the veins. That then pushes on those valves, makes them incompetent. So now you have backflow of venous blood instead of it going back up directly to the heart. What you're going to see with this is edema. You'll see that altered pigmentation that I talked about before, that brownish discoloration. It can almost look like, it kind of reminds me of like kids when they've been out playing in the dirt, that the legs look dirty. But that brown discoloration is because of this chronic venous insufficiency. Typically for venous problems, we see an increase in symptoms in the PM. Skin can be dry and cracked. Our biggest issue with these, with chronic venous insufficiency, you can see the development of cellulitis, you can see DVTs develop, and they often can develop what we call venous ulcers. And we typically see them on certain areas, particularly the malleolus. That's a very common area for a venous ulcer. So when we look at leg ulcers, and you can see the numbers up there, most of your leg ulcers are going to result from chronic venous insufficiency. Okay, you usually see these on the medial or the lateral malleolus. They tend to be larger. They're more superficial. They don't go as deep. And they tend to drain a lot. They have a lot of exudate. On the flip side, the arterial side, Um, these tend to be smaller ulcers. They're circular. They tend to be very deep. You see them a lot on the tips of the toes or like in spaces between the toes. Um, so again, being able to distinguish a venous ulcer from arterial, you can tell a lot based on the characteristics. So anytime somebody has a leg ulcer, whether it's venous or arterial, and you can see some in the pictures, you can see some pretty nasty type stuff there. A is more arterial, and B, is looking a little bit more venous. C is definitely a venous ulcer there, as well as the one on the bottom. But you always want to assess their history of their condition. How long has this been going on? How long has the wound been there? Does the wound appear infected? Okay. What does the wound look like? The color, the drainage, what type of drainage, how much. What does the surrounding tissue look like? That's really important. Are they experiencing pain? What's their circulation status? How are their pulses above and below that particular wound? What's the level of edema? What's their nutritional status? Okay. If your patient has low protein levels and low albumin levels, they're already predisposed to edema. So do we have that going on top of this already problem with the vascular disease? With the leg ulcers, our overall goal is to restore the skin integrity, because we know a break in integrity is a portal of entry for infection. And particularly in a diabetic patient, these are the type of ulcers that lead to amputation. So some things to kind of look at the differences. From arterial, you have that intermittent claudication, so you'll have pain with activity that'll go away with rest. The pulses will be diminished or absent. You'll typically have dependent rubor and edema. So if their legs are hanging down, they'll kind of be like a red rubor type color and they'll be swollen. But once you elevate them to heart level, that rubor will go away and that edema will lessen. They will have dry, shiny, cool skin. Often they won't have any hair on their toes, particularly our men. These ulcers, the arterial ulcers, you see them a lot on the toe, on the heels, on pressure points, and they tend to be very painful. They're circular in shape and they tend to be very deep into the tissue. Color-wise, they tend to be pale to black. And again, the big difference between arterial and venous is for arterial, there's not going to be a lot of edema unless that extremity is in a dependent position. Whereas when you look on the venous side, they don't have a problem with peripheral pulses. And they're going to have edema like all the time. Their skin is very thick, it's very tough. Color-wise, it's like a reddish blue to a purple color. It's not uncommon for them to get dermatitis or cellulitis. The ulcers tend to be a little bit more superficial. They're not going to be as deep. They're very irregular versus the circular arterial ones. And your venous ulcers will tend to show granulation tissue when you're looking at the wound bed. So what do we do about these leg ulcers? Well, the treatment's really going to depend on the cause. I mean, if it's arterial and the problem is with blood flow to that extremity, we have to address that. If the problem is with, venous insufficiency, we have to address that. So you have that piece where you're kind of treating the underlying cause. If there is a cellulitis involved, typically they're going to be treated with oral antibiotic therapy. Compression therapy with stockings, wraps, and for venous. The actual wound itself may be treated with a dressing. And if you go back to your basic wound care principles, if the wound is dry, I need to add a little bit of moisture. If the wound is wet, I need to soak up some of that moisture. So we're going to get a dressing that is going to fit with the needs of the wound. If there's necrotic tissue in there, that wound needs to be debrided. We are making a lot of progress with VACs, those vacuum-assisted closure dressings, and using hyperbaric oxygen chambers to help stimulate growth of granulation tissue. We certainly want to improve physical mobility. Initially, it might be restricted depending on how severe the ulcer is, but we always want to look at activity to promote blood flow. Again, if we don't do something here, this can very easily turn into an amputation situation. So we really need to be proactive with this. Um, Pain management is important. Nutrition is going to be important in helping to provide the building blocks to heal these wounds. So, thinking about protein, your vitamin A, your vitamin C, your iron, your zinc.